Tokyolive Endoscopy 1.
So, hello everyone. Welcome to this session. The topic is a gastric poem. So, I'm Haru Inoue, Showa University Koto Tels Hospital. My co-chair is Dr. Lee Schwanström. So, it's my great honor to introduce him. So, he is the professor of University of Strasbourg and the Chief Innovation Officer, IHASU Strasbourg. And he's also a clinical professor of surgery, Oregon Health Science University, Portland, US. So he will co-chair of this session. So Lee, please introduce our speakers.
Thank you, Haru, and it's a pleasure to be here at Tokyolive once again. So it's my great honor to introduce my colleague and good friend, Professor Silvana Peretta. Silvana is professor of surgery at the CSU in Strasbourg, and she is also our education director for the IHU Strasbourg as well. So I think can't imagine anybody better positioned to give this talk. So Silvana, it's nice to see you, and we look forward to your talk.
Thank you. Thank you very much, Lee. I will share my screen now. And thank you very much, Aro and everybody for having me. It's a great honor and a pleasure to be there with you. I hope that we can soon see each other in person, not virtually anymore. So I took the liberty of slightly changing the topic more towards a, I would say, image-guided myotomy procedure performed endoscopically, not only applied to the gastric poem, but also to the esophageal one, because as you know, and myself and Lee, we are mainly perform in esophageal poem. And nothing to disclose from my side, and but just a big kudos to you, Ara, because I think you really changed the paradigm on how we think about functional disease today. And you really made a tremendous shift from holding on to old dogmas and transitioning to the future of flexible surgery of the GI tract. And indeed, poem made history, because thanks to you and to your effort, poem became one of the world most performed procedure to treat achalasia today, with more than 7,000 poem being performed worldwide. Poem made history also from an academic point of view. We have more than 1,000 papers, peer-reviewed papers published on the subject that shows that results have been excellent, not only in terms of symptom reliefs, but also results have been objectively measured from a physiologist standpoint, showing a decrease in the obstruction to flow that characterize achalasia and also pyloric stenosis, with a consistently good success ranging between 80% and 100% at the short and midterm, comparable to all the different shades, I would say, and subgroups of achalasia. We have results coming also from the group that Lee is leading in Portland that shows that the results are consistent over time and with very promising 5-year results. What we do know is that results are comparable to the Heller procedure. And this is very important because recently there has been a lot of talk against POEM regarding the likelihood of developing gastroesophageal reflux disease. What is clear from the literature today is that neither of these procedures are perfect in terms of very long-term outcomes and control of GERD, and that it is true that if we do have a higher rate, higher likelihood of developing gastroesophageal reflux disease after POEM, which can range from 40 up to from 30% to up to 58% in in some series. So 1 out of 2 patients might develop some sort of gastroesophageal reflux disease. What we do know very well is that there are some risk factors that can be identified. A full thickness myotomy, a posterior versus anterior myotomy, a myotomy that is more than 2.5 centimeter length on the gastric side, the procedure duration, which is a proxy for a more complex dissection and procedure, female sex, and low preoperative LES pressure might be associated with a higher incidence of developing GERD. But the reason why I'm highlighting this particular factor is because you will find everything in the literature. The literature is a wild and confusing compilation of evidence. And this is the case because there is a lack of evidence based on physiology, and there is a lack of image-guided procedure. Why is that? If you look into the literature, even in papers coming from groups that are world leaders in endoscopic treatment, they all have their very personal and peculiar way of identifying landmarks. You will find that people talk about high-resolution manometry is a main landmark for the length of the myotomy, LES, proximal level of esophageal contraction. This is very confusing because you have to ask yourself, how can you possibly see a lower esophageal sphincter during endoscopy? Can you actually see pressure? So this really calls from a more objective way of understanding how we should perform this procedure at the level of the LES, so the esophagogastric junction, but also at the level of the pylorus, probably. And only if we use image-guided and an image-guided approach, we can really understand what's the balance between being aggressive enough to decrease the obstruction to flow and to relieve these dysphagia, but not too aggressive so that we will increase the rate of totally damaging the gastroesophageal anti-reflux barrier and creating gastroesophageal reflux. And actually today we can do that, and we can do that very well if we use intelligently the preoperative and intraoperative images that we have. And those might also be not so sophisticated images. We don't need to go to the EUS or the OTC imaging in order to understand how long and where the myotomy should be located. We can use upper GI series, high resolution manometry, the endoflip probe, the functional lumen impedance planimetry probe, which I will talk a little bit more about it later, or we can use much more refined technologies such as confocal microscopy in order to really locate the lack of the loss, I would say, of myoenteric plexus integrity within the myotomy tunnel in order really to locate where the disease is and reduce the potential collateral damage that could increase the rate of failure and gastroesophageal reflux disease. I'd like to spend a minute on the FLIP probe, the functional lumen imaging probe. This is a probe that I'm particularly keen of because we have together also with Lee and Bernard Delmagne, we really contributed to the development on the probe used to treat functional problem of the foregut, surgical or endoscopically approached. And this is a catheter-based impedance planimetry in a bag that can be filled with electrolytes fluid to 30, 40, or 50 ml that can assess the distensibility of the gastroesophageal junction or the compliance as a whole, which is the sensibility or length of the gastroesophageal junction or any sphincter, such as also the pylorus. So it can tell us a lot. It can tell us where the obstruction is, how long the obstruction is, and how well you are decreasing the or canceling the obstruction to flow. This has been seen to correlate very well, much better than LES pressure, to the functional outcome and the symptomatic outcome of patient after a Heller procedure, myotomy performed either laparoscopically or endoscopically. And what we do know now that both procedures result in a increase of distensibility, decrease of the increase of distensibility index and diameter of the sphincter that we are assessing, in this case, the gastroesophageal junction. And we do know that patients who have a higher distensibility index and cross-sectional area, which is really the area that is functionally active at the level of the sphincter, have a higher success rate. We also do know that if we overdo it, we can increase the likelihood of developing gastroesophageal reflux disease. Now, what is the problem using this probe, which seems very helpful, is try to standardize the results, because you have a probe, you have a catheter, which can be filled with water, and you can use 30, 40, or 50 ml to distend the sphincter. So how can you navigate throughout this different and versatile probe that you can that you can use in the patient? So today we are coming with a much more standardized approach and with values that we should reach and not overcome in order to give the patient the correct treatment. So we do know that we can achieve success if we have a distensibility index which is superior to 3 for 40 ml distension in the bag, or 4.5 to 8 if we're using a 30 ml distension. And we do know if we have a cross-sectional area that is superior to 96 millimeters, square millimeter, we have a higher likelihood of giving the patient gastroesophageal reflux disease. So if we use the probe to check the sphincter, the LES before and after the procedure, we can actually really focus and target our treatment. And we can do it also in very complex scenario. I'm showing you this case because it's extremely interesting to me. So this is a patient, one of the rare patients who had both an esophageal diverticulum that we did with Lee, actually. And Lee, I don't know if you remember this case, and achalasia. And it was treated laparoscopically. And here we're doing a surgical rescue and a POEM rescue of the surgical failure, doing a double approach with a myotomy of the gastroesophageal sphincter area and the esophageal body, and a septotomy of the diverticulum, which are guided by the endoflip. So we could assess how much we had to cut in order to release the obstruction to flow at the level of the gastroesophageal junction, and at the same time cut the septum in a way that was effective and would not incur into recurrence. What about the use of the endoflip for pyloric myotomy? There is a strong body of literature now starting to grow that shows that this is a tool that can also be effectively used in order to predict clinical response. And we do know that 3 and 6 months after pyloric myotomy performed endoscopically, the distensibility index, the cross-sectional area, and the back pressure do correlate with successful symptomatic outcome. And the distensibility index seems to be the one parameter that could also correlate with long-term success rate. This is important because if we look at all the predicting factor, there are very little that can actually say that that particular patient will do well or not. What's interesting is that distensibility index seems to be also associated to good outcomes in patients who present with diabetes, which might be a category that are particularly challenging to treat. What is interesting is also the timing. This study has been published about 1 year ago by a multicentric group compiling patients both from the United States and Europe, France in particular, is assessing two things. Of course, the impact of the endoflip in predicting outcome, but also, and which is even more interesting to me, which is the best timing of using the endoflip. How should we use it? They use it both before and immediately after the gastric poem was performed, and immediately before and at 3 months. And what they've seen is that there is no difference in distensibility rate assessment at 3 months or immediately after the G poem was performed, but it seems like that the distensibility index and the ability to predict outcomes is much more reliable if the endoflip is used immediately after the G poem than at 3 months, which also makes sense, because should you incur into a result that is not convincing here and there, you can increase your myotomy length, correct yourself the trajectory, and perform deliver a better treatment to the patient. So in conclusion, I do believe, I'm a strong believer, and I think that Lee would agree with me, that today we cannot afford any approximation anymore. No matter if we perform surgery using a laparoscope, a regiscope, or an endoscopic, a flexible scope, we really have to deliver precise, personalized, tailored surgery, especially for functional surgery, which is never the same in every patient. And I think that if we cannot achieve that with our own human intelligence, probably artificial intelligence tools will allow us to have a categorization of what we do, fingerprints of what we do, as very elegantly demonstrated by the team of Dan Hashimoto and Thomas Ward at Mass General, in order to guide us and probably help us achieve a best outcome for the patient and decrease the number of complications. Thank you very much.
Thank you, Silvana. That was a wonderful discussion of the kind of the mature state that poem is in today, and how much further it has to go, in fact. And certainly one of the things that you point out is how inaccurate subjective symptoms are as an outcome measure. If somebody doesn't have access to the endoflip, what other mechanisms do they have to objectively follow their patients? What would you recommend for an objective follow-up protocol after a poem?
So thank you very much, Lee. You mean post-operative follow-up? Yes. Well, symptoms for sure, endoscopy for sure, because we do know that we have to closely monitor the esophagus, looking for consequences of asymptomatic GERD. We do know that POEM patients can develop asymptomatic GERD, which is really the only thing that worries me, because most of these patients will do well on PPI, and very small percentage of them will eventually need to have a fundoplication. But we have to look for mucosal damage, and we know that can be silent. So definitely, I would recommend to have an endoscopy. If they do refer recurrent achalasia or recurrent, I would say, obstruction to flow and dysphagia, I would also do an upper GI series, because it's a simple test that everybody can do, but it gives you a lot of information regarding the emptying of the esophagus, and can mimic what actually can happen while the patient is swallowing real food. So those are two simple exams that are available everywhere that I would certainly recommend to do.
Lee, may I ask one question to Silvana? So, yes. So, Silvana, thank you very much. A great lecture, as usual. And you emphasize, you cover from the esophageal poem to gastric poem, so two related procedures. So you emphasize that the using the endoflip is a very important and useful to evaluate the effectiveness of the myotomy objectively. So I can imagine very well that the EndoFlip works well to avoid incomplete myotomy. So before procedure and after procedure, the distensibility of the LES or pylorus muscle, we can objectively evaluate it. And then please let me know how to use it to avoid too much myotomy. So what I mean is in order to avoid the reflux disease, so how to apply the EndoFlip to avoid too excessive myotomy to the gastric side or duodenal side.
That's a very, very good question, Aro. I think that there are two things. One is really use all the information that the EndoFlip can provide, because the EndoFlip is not only telling you about the cross-sectional area or the distensibility. The EndoFlip is really locating the obstruction to flow. So I always believed that you have to do just what is needed. I don't believe in very long myotomies. I believe in short, tailored myotomies. So if you add the information that you have from the high resolution manometer, which will tell you how long the obstruction to flow is, and you look at the EndoFlip catheter and you look at how and you measure the obstruction to flow, which you can do because every little slit of the EndoFlip is 0.5 centimeters. So you can see how long that is and where that is. And if you know how long and where, you can really tailor your myotomy to that. Oh. So that is the first point. The other thing that you can look at, but once again, this information is still in the process of being, I would say, validated, is you can look at how the cross-sectional area. If you have a cross-sectional area that is gigantic and it's over 96 square millimeter with a diameter that is exceeding 11 millimeters, what has been shown in the literature is that you might have a higher risk. Honestly, me and Lee, we do this very often together. We look at length. And we have been doing very short myotomies. I don't know why people do a 10 millimeter myotomy on the esophageal body, or a 3 centimeter myotomy on the gastric side. That is useless. It's doable, it's fun, it's a lot of fun, but it's totally useless. So I think that we should not be captured by the beauty and of this procedure and really follow physiology and do only what is needed. And I'm sure that the gastroesophageal reflux rate will decrease. Yeah. And perform a myotomy only on the circular fibers, because that will keep you, I would say, in check. It will help you do very little, only what is needed.
Thank you.
Silvana, maybe I'll keeping on that same theme of minimizing reflux. You mentioned not doing a full myotomy. I think there's some evidence that a full thickness myotomy yields more reflux. What do you think about the controversy of posterior versus anterior versus lateral myotomies? Does that have any impact on reflux rates?
I think personally, it does. That is my personal opinion. I don't have enough data to share with you to prove it, but we've been doing this together for over 10 years, which doesn't make us any younger, Lee, but maybe more experienced, more mature. Let's put it this way. And what we know is that in our own series, we have, I would say, 10% of gastroesophageal reflux disease. And we monitor our patients with functional studies and endoscopy. But what we also do know that we have been sticking to the same technique using the endoflip from the very beginning and doing an anterolateral myotomy, always with the only exception of patients who already failed previous myotomy or previous surgical treatment. So I do believe that an anterolateral myotomy that is performed on the lesser curve interferes less with the angle of vis and has a milder effect on the disruption of the anti-reflux barrier. Having said that, I'm sure that especially at the beginning, it would be overreaching saying that I was perfectly sure of being on the anterolateral wall exactly between 12 o'clock and 3 o'clock, because very often, especially in tortuous esophagus, I honestly don't know where I am exactly. And so I think that learning curve more than where you are could have an impact on the rate of gastroesophageal reflux disease. But I like to stick with my anterolateral position, maybe just because I'm more comfortable and have better results with it.
Professor Inouye, maybe you would like to, I know you taught us all how to do the myotomy in the anterior lateral position, as Silvana described. I still do it that way. She does it that way. Are you still doing it that way, or have you changed to another position?
Yeah, thank you very much, Lee. It's under Silvana. So this is a very important discussion when we perform the POEM procedure. So far we performed more than 2,000 cases in our hospital. And our first 500 cases, patient receives anterior myotomy, anterior wall myotomy. And after that, we switched to a posterior 5 o'clock direction myotomy. So we can accept both. So anterior myotomy, posterior myotomy, we can accept both. Just I want to say it's better to avoid the side lateral, pure lateral myotomy, because so if we place bilateral, so anyway, lateral myotomy, so please remember the CT scan. So behind the esophagus wall, there is a lung. So it's a negative pressure in that area. Anterior wall is a heart, and the posterior wall is a supine and the aorta. But the lateral side, there is just a negative pressure organ, lung. So in order to avoid becoming the divert from after POEM procedure, I think I recommend either so anterior or posterior myotomy. So we can accept both.
Great. Thank you, Haru. I don't know if we need to move on to the next talk, or do we?
Yeah. I'd like to introduce the next speaker. Thank you very much, Silvana. A great talk.
Thank you, Silvana.
And we'd like to move on to the next speaker. The next speaker is Dr. Jan Martinek. He is a full professor of Charles University in Prague. So he is of course, he's one of the great performer of the POEM procedure in Europe. So, Jan, please start your lecture.
Thank you, Professor Inouye. Thank you, Lee, and welcome everybody. My task is to speak about gastric POEM, how good or bad it is. GPOEM means endoscopic pyloromyotomy, and it should be, or it could be performed in patients suffering from refractory gastroparesis. It's a younger sister or brother of Inouye's esophageal POEMs, consisting of the following steps: mucosal incision, tunneling, and finding pyloric ring, myotomy, and closure of the mucosal incision, usually by endoclips. Gastroparesis is a severe disease, or can be very severe, defined as a slow gastric emptying without organic obstruction. And in contrast to achalasia, gastroparesis is much more difficult disease. There are different etiologies, such as diabetes or systemic diseases, infections, or after surgery. 30% of subjects, they don't have known etiology, and we speak about idiopathic gastroparesis. And the pathophysiology is complex and multifactorial. And this is very important to keep in mind when considering pylorus-directed therapies. The pylorospasm is only one part of the story. There is gastric hypomotility or uncoordinated antral contractility. There is a loss of gastric pacemaker, meaning the cachal cells. There is a smooth muscle atrophy and many other problems. To be short, there are two main parts causing gastroparesis, is a hypomotility and pylorospasm. We don't know which is more important and less important, and it can differ from one patient to the other. And treatment of gastroparesis reflects really this multifactorial etiopathogenesis. We can use and we should use dietary measures, drugs including antidepressants, and these psychofactors play an important role. We should treat an underlying disease such as diabetes. There is a need for nutritional support with enteral nutrition or PEG-PAY. Other methods such as electrostimulation, venting gastrostomy, and so on. And pylorus-targeted or directed therapies consisting of dilation, Botox, GPOM, or laparoscopic pyloroplasty, this is really only part of the story. Here you see an image of electrostimulation, which is considered also not a standard procedure for gastroparesis, still under investigation. And it's an interesting study comparing retrospectively two different cohorts with gastroparesis. Part of subjects had electrical stimulation, a second part had a GPOM. And you see that in this retrospective analysis, the GPOM had higher success rate, 77% at 2 years, versus stimulation, 54%. But once again, the hypomotility we target by prokinetics or stimulation. Pylorospasm we treat by using pylorus-targeted therapies. Other factors we influence by using psychology or psychiatric interventions, diet, treating of underlying disease, and so on. And we shouldn't forget that in contrast to achalasia, in gastroparesis there can be very huge placebo effect. So gastroparesis is too complicated disease for a simplistic therapeutic approach, and that's why we shouldn't expect GPOM would be as effective as esophageal POM in patients with achalasia. How to diagnose gastroparesis? Usually the standard method is a scintigraphy. The main parameter is gastric retention at 2 hours. If it is more than 10%, it's a proof of gastroparesis. But scintigraphy does not tell us anything about pylorospasm. Gastroscopy is not a good method to diagnose gastroparesis because majority of patients, they have a normal finding, but some patients, they have this food retention in the stomach. Silvana really nicely described the role of endoflip in both esophagus and pylorus. And I do think that impedance planimetry measurement is really promising to diagnose a pylorospasm. And I believe also that it could also target our therapy in terms of pylorus-directed therapies. However, there are no normative values for pylorus. We don't know what is normal distensibility, cross-sectional area, what are the cutoffs, and so on. We don't have standardized protocol. If you measure endoflip, it's not really easy in a pylorus. And intraduodenal manometry, it can diagnose pylorospasm, but it's not readily available. Here you see that we measure endoflip before and after GPOM You see that the difference from low distensibility to increased distensibility during the procedure. But we don't know how, for example, the pyloric distensibility is influenced by general anesthesia. It's also an important point. Or by food intake. If we measure distensibility, the stomach is empty. But what happens with pylorus if there is a food? And this is maybe the most important parameter. So endoflip today is not ready to be standard examination to diagnose pylorospasm because there are no normative values, no standardized protocol, and not known inter-individual variability. And but I hope the endoflip is really promising technology. Can endoscopy predict a pylorospasm? Here you see a patient where we see the pylorospasm, but endoscopy is a subjective examination to assess pylorospasm. Here you see our patients who underwent GPOM, and all these pylorus tend to be spastic, but these pylorus could also be within the normal limit. So endoscopy is not good enough to diagnose pylorospasm. We don't perform GPOM in those with largely open pylorus. These patients we don't recommend the GPOM. As you already know, that the first GPOM was performed by Mu and Kashyap, published in 2013. We performed our first case in 2015, should be number 17 in the world. And I would like to show three big studies published last and this year. The first is a prospective study published in GUT, multi-center, where at 12 months, the clinical success, which is defined according to symptomatic response, was 56.3%, quite a moderate treatment success. The second study is a French multi-center study, retrospective, where the treatment success at 1 year was 66% of subjects. And the last is an American experience with the initial treatment success of 81%. At 1 year, it decreased to 69%. So it's much less compared to achalasia. Here is the summary that at 1 year, the treatment success ranges from 56 to 69%. These are our small series published last year that we had a treatment success 75%. And throughout among these studies, gastric emptying usually improved. What about predictors? Predictors are really difficult issues. These are predictors published among studies such as pyloric distensibility improvement, etiology, female gender, duration of symptoms, pain medication, high body mass index, and so on and so on. The problem is that each study has found different predictors and there is no agreement. So it's a big mess. I would say there are no reliable predictors of treatment success failure, and maybe the most promising are endoflip values, but still we don't know what the pre-treatment values predict treatment success. What about recurrences? Also a very large controversy. The US study showed that loss of response is 13% per year. So the initial treatment success decreases in time. On the other hand, the prospective study showed that in patients having treatment success at the beginning, usually the rate of treatment success is rather stable. So we even don't know how good or bad the results, long-term results of GPOM are. And what about non-responders? Are all non-responders patients without pylorospasm? It's a case. We performed a 30-year-old lady with post-surgical gastroparesis. We performed first GPOM 2018, no effect. This is gastroscopy after first GPOM. We performed endoflip. Here you feel the spasm, persisting spasm. The distensibility at 50 was 3.7. So we offered her a second POEM, re-GPOM. We did a new incision at 9 o'clock, And you see that we had a problem that our incision, mucosal incision, became larger. We performed a short tunnel, short myotomy at 9 o'clock, and then we closed the incision by using suture system. And there was a huge improvement after second POEM. She gained weight, and the scintigraphy improved, not after first, but after second, and symptomatic score improved dramatically. So it's a question, should the double myotomy be a standard or a single myotomy? I think this is exactly what Silvana showed us. We need a tailored approach, because I am sure some patients will need a single myotomy, some maybe double myotomy. Or maybe the first myotomy was not well performed by me. It's also a possibility. And GPOM in patients without gastroparesis, it means negative gastric emptying study. This is a patient suffering from severe dyspeptic symptoms, gastroparesis-like symptoms. We measured endoflip. We really proved that there is a pylorospasm. We performed balloon pneumatic dilation with the effect, short-term effect. And then we offered GPOM, and the effect was tremendous. So 6-month effect, 100% improvement. So maybe GPOM could also be offered to patients with pylorospasm without gastroparesis. GPOM is a safe procedure, but we should really look at dumping syndrome. There is no reported dumping syndrome in these 3 studies I mentioned. However, we had one case with quite severe dumping syndrome in one patient with severe diabetic gastroparesis, and this should be looked at because severe dumping syndrome is not easy to treat. The second nice complication is one patient developing bleeding and large ulceration after GPOM. You see here the video. The pylorus is here. This is the myotomy pylorus, and in fact the mucosa covering the tunnel disappeared. Here is the pylorus open after myotomy. So we were lucky enough that this patient was cured on PPIs. The reason for this complication that somebody withdraw PPIs too early. So please keep PPIs at least 4 weeks. We are now finishing a randomized sham-controlled trial of GPOM in patients with refractory gastroparesis, and some patients without treatment success were offered crossover GPOM. This study should terminate at the end of this year. So I think this is very important study, and I hope that the results will be of general interest. This is the future perspective that not only gastroparesis, but maybe some patients with functional dyspepsia, if they have a pylorospasm, we don't know how to diagnose it now, but in future we will have maybe validated endoflip. If there is a pylorospasm, we can offer GPOM, but GPOM is not the end. We should continue other treatment approaches if necessary. If there is no pylorospasm, there is no place probably for these therapies. ESG recommends that GPOM should be performed in expert centers only, preferably in the context of a clinical trial. So in contrast to POEM, GPOM is still a method under investigation. And future selection of patients with pylorospasm is a key. GP is a difficult disease, gastroparesis, and GPOM will not cure, but rather improve symptoms. And sham-controlled randomized study is necessary, and I hope the results will be available soon. Thank you very much. And this is a picture from Prague, and we send the greetings to Tokyo.
So, Jan, thank you very much for the great lecture. You cover the very wide area of the GPOM, so starting from an indication and your clinical results and the review of the article complication and the future perspective. So I have a question to you. It's you mentioned about the in some patients double myotomy is effective. So would you select the patient beforehand or So you place one myotomy and then it's not effective, and then end flip are still tight pylorus, then you proceed to the second myotomy. So, please let us know.
So we do perform one myotomy as a standard. We never perform double myotomy during a single procedure. Mm-hmm. But we are thinking that we should measure the distensibility at the end of the procedure, and maybe to place the first myotomy not at 6 o'clock, but at 5 o'clock, for example. And if there is no enough improvement in terms of distensibility, then to be able to place a second myotomy. But this must be everything studied. This is only our thinking. There is only one study showing that double myotomy may be more effective than single myotomy. So we need more data, and we are thinking how to implement endoflip measurement to target, to tailor our therapy. So I don't think double myotomy should be standard without endoflip measurement, definitely not, because, for example, of dumping syndrome, but it's a nice idea, and we are thinking to design a study with this or something like that.
Sir, thank you very much. So, Silvana and Lee, and any comments or question or comment or discussion, please?
I have a question for Jan. I'll add my compliments. That was a nice summary of a very complex topic. As you know, these gastroparetic patients present with very specific different symptoms. There's abdominal pain and bloating, there's severe nausea, and then there's vomiting and essentially obstructive symptoms. Do the types of symptoms help you decide what approach to take, or are they all pretty much equal? In studies, and there are many other studies I didn't mention. In some studies, these symptoms, especially nausea and vomiting, these are predictors of treatment success, and less nausea and vomiting, more treatment failures. But it's not homogeneous. It's reported in some, but not reported in other studies as a predictor. So at present, we don't select our patients based on how severe the first subscale nausea vomiting is, but it's also an important point. But I do believe maybe more that we should in the future target our patients for GPOM based on endoflip measurement or diagnosis of pylorospasm, because there are many patients in my experience without vomiting, with little nausea, with severe abdominal fullness, with huge improvement after GPOM. So it's also under investigation, and it's an important point. I would like also only to add one sentence to Haru's question before, that the case I showed you also is showing, and this is not the first case, there are some re-GPOM cases published, that the re-GPOM is feasible, that if it doesn't work, you have persistent pylorospasms, so you can do the re-GPOM, and it's feasible. This is the argument that you can do the second GPOM if necessary.
Any other question?
Yes, I have a couple of questions. First of all, congratulations. I really enjoyed the lecture. It was very nice and very clear. My question is, do you think there is a role for Botox injection in terms of predicting the success or failure of the GPOM? And then a technical question. My personal experience has been that sometimes it's much more complex to close with standard endoscopic clips the mucosotomy that you have performed in order to perform GPOM. Would you suggest other means of closure, such as, for instance, endoscopic suturing? And do you have any experience with it?
Thank you, Silvana, and also thank you, Haru and Lee, for your questions. Botox, I was in charge because there is last year ESG guidelines for motility disorders were published, and I was in charge of Botox and as a pre-treatment and to select patients for GPOM. In fact, ESG does not recommend or recommends against the use of botulotoxin to select patients for GPOM or dilation. The main reason is that there are two randomized studies showing that the effectivity of Botox is the same as placebo. So if there is a good result of Botox, we don't know whether it's Botox or placebo, and the placebo response rate is really huge. So I wouldn't recommend it. Even I know that some centers, they do it with some. There is one study showing that it makes a sense and that the treatment success in those who responded to Botox was better after GPOM than in those who didn't respond to Botox, but it's only one study. And the closure, we are now writing a manuscript. Today I received the pre-final version. We are thinking where to send it, where we prospectively compared clips and suture system, Apollo. And I would advise that everybody, in contrast to the esophagus, where clipping in the esophagus is easy, that everybody performing GPOM should have some rescue methods for closure, because clips do not work every time. And we had two cases where we needed to use another closure method, either suture system or with endoloop based. So the clips, there should be a rescue method. Apollo system is to us too expensive. So we start with clips, but we are ready to use suture system. And you saw the case with the re-GPOM. There was this incision, the tearing, the mucosa, really, it wouldn't be possible to close with clips. So this could happen. And this was also the reason why we don't perform longitudinal mucosal incision, but we do transversal, because in one case, the mucosal incision split just at the level to the level at the pylorus, and then without the suture system, we wouldn't be able to do a myotomy. So suture system is good as a backing or endoloop-based system, and transversal incision is our current practice.
Thank you.
So any other comments?
I'll really give you, you mentioned this, but I just want to stress to the people that are listening that, and really compliment you on doing the sham prospective randomized trial, because when you see those results with early results of 89% success going down to 60 or 70% success, that's probably placebo effect. And as you mentioned, these patients are very prone to placebo effect. They're so desperate and they want to be better. And so I think I'm excited to hear the results of your study when it's complete. So congratulations for that.
Thank you. Thank you.
So thank you very much, everybody. So we are strongly waiting for the sham study results. And once again, I really appreciate Silvana. You are covering both the esophageal poem and also the cross relation, the gastric poem, the usefulness of endoflip. And the Jam has you talk about the everything. So current status of the G poem. So we once again really appreciate the resource frame, your nice comments. So thank you very much, everybody, and have a nice day.
Thank
you, Haro, and good luck with the rest of the meeting.
Thank you
so
much.
Bye-bye.
Bye-bye.